Good evening, everybody. I said I would get on here and do a live about Foley catheters. Not the subject I was expecting to ever chat about, but of course, suitable. We must talk about them. Foley catheter, if you don't know what that is, basically it's the number one treatment used for people, men and women, experiencing urinary retention. Retention is when you are not voiding, you're not urinating fully or adequately. And that's the way they know this is by measuring what's called post-void residual urine volume. And an inadequate voiding amount, so what's considered urinary retention is if it's more than 200 milliliters. What's considered adequate is less than 50 milliliters, okay? 200 milliliters is about a can of Coke or anything, soda like that. Soda can, pop can, whatever you want to call it if you're from the north or south. Up north in Chicago, we call it pop. Down here in Florida, I guess they say soda. Anyway, okay, so if people are experiencing retention, that's also if you are in the hospital because you are delivering a child, a baby in the hospital. Sometimes Foley catheters are used on women who are about to give birth, or women who have given birth and they just can't urinate, and the nurses notice that they're retaining and they're not voiding, they're not urinating, so they put in a Foley catheter. So what is that? It's basically a tube, a little tube, like the size smaller than your pinky size. Hopefully. Or the size of your pinky, depending on how big your pinky is. And it's a tube that's connected to a Foley, which is a bag that collects the urine. That tube is inserted in the urethra. So if you don't know what your urethra is the little tube that comes from your bladder where your pee comes out from. Women, your urethra is not the same hole that you bleed from, and it's not the same hole that you give birth to a baby from. And it's not the same hole that we have sex with. That's not your urethra. Your urethra is above there. If you took a hand mirror and you put it down to your vag, your urethra would be, it's like a tiny little gray dot above your vagina, your vaginal canal, the other hole that I'm talking about. The last hole on the bottom, let's say you're looking at yourself lying down in the bed, the last hole on the bottom would be your anus, your anal canal, your butthole, right? So if you're looking at yourself with a hand mirror and you're laying down, you would see from top to bottom, well, first you'd see your clitoris, okay? The clitoris is that little knob at the top. There's no hole there, but you do have something called the clitoral hood, which should be flexible. I'm going a little off topic, but that's okay, because you ladies that are in here, everyone, all women, all people should know about their parts. That's the problem. We don't talk about our parts enough because, I don't know, it's taboo. There's so many reasons that I just don't want to talk about right now. But there are a lot of people. I should have an interview with someone who's really good at talking about different reasons why we don't like talking about our pelvic floor. It's like how we grew up, right? These like falsehoods that we're fed since the beginning of our lives. Anyway, okay, so from top to bottom, if you're looking at yourself, you have the clitoris with the clitoral hood that should be flexible. You should be able to move it back and forth. Sometimes things can get stuck up there and can cause a lot of irritation, ladies. So if that's happened to me when I used to ride my bike a lot, and I had like tissue that got stuck up there, and I was like, what the hell is going on? It was like the worst feeling ever. Never felt that before. And I was washing, I was cleaning, but apparently not it wasn't good enough. I had to move. This is TMI, but I don't care. This is important. You can move your clitoral hood and clean under there the same way men can clean their penises and move their foreskin down. Sorry, I just thought about something else to do with foreskin. There's a reason we have the skin there, so removing it is not a good idea. On women, it's not a good idea, and on men, it's not a good idea. Anyway, you can remove stuff if that's ever happened to you. Use a little Q-tip, and you can fix that. That happened to me. I was riding my bike a lot, had some irritation. I was wiping. Maybe I was wiping too hard, who knows? But there was like a tiny little bit of tissue that got up there. And in one day, it can cause a lot of irritation. Okay, anyway, so you have that. Then you have what do you have? What was I talking about? Your urethra. It's a little tiny gray dot going down the line from top to bottom. Then you have your vaginal canal. And then underneath that, you have your anus. Okay, so, wow, I'm totally off topic right now, but it's okay. This is good. So post-void residual volume is the amount left over. If it's an inadequate amount of urine voided, so that could be after delivery, they might use one of these Foley catheters. It's the tube. They insert it into that little gray hole, little gray dot. Yes, it can be very painful, especially if you have an obstructed urethra, which in some cases people do, especially older adults with multiple systems atrophy or just really weak, deconditioned people that have a neurogenic bladder, which I'll talk about that later. Wow, we're gonna go all over the place today, but this is fun. I haven't done this in a while. And so beautiful. I'll get to your questions and comments, guys, in a bit, but I really want to get this off my mind. So you can be someone who just delivered a baby and they may insert a Foley. So once they put that tube up, then there's like a little bubble that they inflate. I'm not sure how the nurses do it, but they have like a device that they use to inflate that bubble once it's inside of the bladder. And I believe they use ultrasound to make sure that it's up there before they turn on the bubble, or I'm not sure exactly how they decide it's up there. So once it's in there, in the bladder, okay, they go through the urethra, which leads up to inside your bladder. Once it's inside your bladder, they turn on this bubble, and the bubble keeps it from coming out. That bubble is just before the end of that tube. So there's a little more of that tube above that bubble, and I believe that's where the hole is to collect the urine that's left over in the bladder to drain into the Foley, okay? So, okay, let's think about this. Remember, the bladder is only the size of the contents that is inside. So your textbooks, when you're in school and they're depicting a bladder and they're showing it half full or half empty, however you want to think about it, they usually draw like a pink outside bladder looking shape. Amorcito, come on. Good boy. And then they draw yellow urine like half of it, to show that it's half full. And that's actually poor depiction of a bladder, because your bladder is really just the size of the amount of urine that's inside of it. Okay, so that being said, they use this. This is the number one treatment for your urinary retention, especially if you're in the hospital. Even if you're just there acutely, like for a short time, because maybe you're having a baby, they might put that Foley in you, okay? They might put that Foley in you. And it's never really full consent, guys, because they never really fully tell you everything to expect. They don't warn you that, hey, when we take it out, you might not be able to urinate still. And we're actually going to do more trauma to your pelvic floor. So it's going to actually make your urge and, well, maybe not urge. It'll make your retention worse. You will have urge and you will have sensations of frequency. You will have urge and frequency. Okay, they don't warn you that stuff. This happened to a client of mine. And she's still experiencing difficulties over a year after delivering, right? Okay. So this is regardless of the reason that you're having difficulty urinating, this is the number one intervention. This is just what they like to use. Okay. What happens? So why, after they remove it, do women experience, I'm going to just stick with women, but men, it's the same stuff. Same muscles, same idea. Anatomy is a little bit different. Yeah, it's... Hey, amorcito. Oh yeah, he loves running in the mud, right? You had to go right through the puddle, right through the mud. Okay, so things can occur. They call them Detrusor hyperreflexia. Detrusor hyperreflexia, or Sphincter-Detrussor dyssynergia. Sphincter-Detrussor dyssynergia. Okay, I've done a live about this before, about the urinary bladder, the anatomy and physiology of it. I'm probably gonna dive into that a little bit again right now. I think I just swallowed a bug. Okay, so what is the detrusor? The detrusor is a muscle, the muscle that's inside the bladder wall. Okay, so detrusor hyperreflexia refers to the detrusor reflex is when it contracts. Okay, it gets a message from the pontine micturition center in the brain, from the pons. It gets a message, that message goes to the spinal cord, and then the message further goes down to the bladder. When the bladder is full, this is how a normal functioning bladder works. When the bladder is full, when that detrusor muscle is stretched, the stretch receptors send the message up. Once that pontine micturition center gets the message about how stretched it is, it gives you an urge sensation, and then when it's time, it sends a signal back down to the spinal cord, and then to the bladder. Amorcito. And then the detrusor muscle will contract, okay? It contracts to help eliminate the urine, okay? So detrusor hyperreflexia is a condition where the detrusor muscle is just contracting too much and at the wrong time, and without enough of the bladder filling, without enough stretch of that detrusor wall. Then there's also something called Sphincter-Detrussor dyssynergia. The sphincter, that refers to, well, there's two sphincters when it comes to the bladder. You have the external urethral sphincter, which is part of the pelvic floor muscles, voluntarily controlled. Come on, amorcito. Amorcito. We gotta go this way. Come on. There's people. Gotta get away. Okay, so then that's part of the pelvic floor. Then the internal urethral sphincter is actually an extension of the detrusor muscle. It's more superficial, or not superficial, deeper to the external urethral sphincter. So the external urethral sphincter is more on the outside. That's why it's part of the pelvic floor muscles. And then the internal urethral sphincter is involuntarily controlled, an extension of the detrusor muscle. Okay, so when talking about Sphincter-Detrussor dyssynergia, it could be referring to the sphincter, just internal, just the external, both. That has to do with different parts of the nervous system. So the internal one would have to do with the autonomic nervous system. The external urethral sphincter has to do with the somatic nervous system. That's the volitionally controlled part of the nervous system. Did I say autonomic? Yeah, the autonomic nervous system, because your internal urethral sphincter. Woo! Come on. Oh gosh, there's frogs on the floor. If he eats them, that's not good. Amorcito, come on. It's not good. These frogs are poisonous for dogs. But people walk their dogs here all the time, so nobody's said anything about having an issue here. Okay, yeah, so the autonomic nervous system is involuntary. So the internal urethral sphincter, yes, that's the involuntarily controlled one. And the volitionally controlled one is the external urethral sphincter, which is part of the, it's primarily controlled by the somatic nervous system. This is part of the motor fibers, the same ones that control our pelvic floor muscles, the volitional ones. Okay, hang on one second. Okay, so think about this. So a post-void residual volume of more than 100 milliliters or more than 1/3 of your bladder's capacity is considered incomplete emptying, okay? So now, picture that, and someone who experiences this all the time. Psst, amorcito, hey, come on, heel. Good boy, he's coming fast. Okay, so if someone experiences this often, and this is even in the hospital, okay? Sometimes they don't leave the catheter in there. They'll just go in to get the urine out and then stop and then do it again later, okay? Doing this a lot can actually exacerbate voiding dysfunction. You can actually make a detrusor's overactivity worse, okay? And just this whole condition, it's like this vicious circle. The whole voiding dysfunction can exacerbate the detrusor overactivity, and an overactive bladder constantly stimulated by having residual volume, like over 100 milliliters, or just having extra urine in there, will constantly cause this detrusor muscle to contract, to respond. And this is what produces these symptoms of frequency and urgency. Okay? It's the same function. It's the same physiology. Okay? So not fully emptying will cause you to keep feeling like you have to go, because your detrusor muscle that's involuntarily controlled. This is just the nervous system that you can't control unless you train it. You can train your bladder. There's such thing called bladder training. That's what pelvic therapists are all about. Okay, you can use your voluntarily components of nervous system to override all of this and reprogram yourself. Okay? You can reprogram yourself. Again, guys, I'm sorry I'm not looking at any of the messages right now. If you do have comments or whatever, I can't read them because I will get so distracted. So I will read them at the very end of this. Okay? So urinary continence requires coordination of both the autonomic nervous system and the somatic nervous system. It requires the coordination of both of these parts of your nervous system. So while the pelvic floor muscles are the voluntarily controlled parts of your body that you have control over, there are other parts to your body that you don't have voluntary control over. Okay? The other parts of your nervous system. That's why some people that have a spinal cord injury, or even if you have any kind of insult to the brain or spine, to the nerves, whether it's disease or an injury, disease can cause disruption in the message from brain to and through the spine, right? Like MS and just different spinal cord injuries, traumatic spinal cord injuries or non-traumatic spinal cord injuries, like from compression fractures, all of that. That leads to neurogenic bladder. That's when you have an issue with the message getting through the body, through the spine, from the brain to the spine, through the peripheral nerves. You might even have an issue in the peripheral nerves. So not the brain or spine, not the nerves in the brain or spine, but the peripheral nerves that are outside of that. Whoa, what's that? What's that? So that's called a neurogenic bladder. Come on. He's fine. Come on, Amorcito. Where's that sound coming from, baby? I hear it. Oh, he's across the water with his owner. He's fine. Okay. Okay, so remember, having this issue, a voiding issue where you can't completely void, that exacerbates Detrusor overactivity, and it exacerbates an overactive bladder, because that bladder that's constantly being stimulated by more post or void residual or just residual urine in the bladder will keep getting stimulated and will keep getting message down from the Pontine-Micturition center in the brain. So pons, look it up, the pons in your brain. It gets a message saying that it's got urine and that it needs to go. Someone asked, I think, a question about why thinking about it. Why does thinking about it make you feel like you have to go? Same reason. Pontine-Micturition center in your brain. You're like sending information there. Okay. No, I don't have a flashlight. Okay, let's talk about this briefly. Okay, so not only is urinary continence, not only does it require coordination between the autonomic nervous system and the somatic nervous system, that's the involuntarily part of urinating and the voluntary part of urinating, but it also involves elements of volitional control, right? That's the pelvic floor, and also assessments of social appropriateness. So us being cognitively with it enough. Whoa. Hey, psst, nope. Come on, baby. I don't know if that's a gator or a big fish. We'll say it's a big fish. Because there's gators down here in Florida, guys. But my dog's a pretty big dog. Okay. Okay, so urinary storage, again, I talked about this before. If this is boring you guys, that's fine. You can get out. I'm doing this for those who are interested in learning about the anatomy and physiology of the urinary bladder. It's important to understand proper functioning if you want to understand dysfunction. So the only way I can really teach you about dysfunction, and I know I talk about dysfunction a lot, and people are like, you need to talk more about function. So here I am. To understand dysfunction, you have to first understand function. Okay? So urinary storage, right? Your urine is stored when you're running from the line, right? So when you're running from the line, your sympathetic nervous system is turned on. So that's when your urine needs to be stored. That's primarily mediated by the involuntarily by the sympathetic nervous system. Okay? And it's also volitionally mediated by the somatic neurons to the external urethral sphincter, right? The pelvic floor muscles that we can control. Psst. Hey, you're going a little too far there, babe. He's down here by the grass and he's just having fun. At low bladder volumes, so when you don't have a lot of urine stored, there's contraction of the internal and external urethral sphincter. It's maintained by those sphincters, the contraction, right, to store the urine. And the detrusor muscle contraction in the bladder wall is also inhibited. So the detrusor muscle is relaxed, if you want to think about it that way. So when it comes to micturition, urinary voiding, letting go of urine, the parasympathetic fibers of the nervous system in the pontine micturition center is what mediates that. At higher bladder volumes, the descending fibers from that pontine micturition center activate the parasympathetic fibers in the spinal cord, which then will cause the detrusor muscle to contract and the urethra to relax. Okay? So there's urethral relaxation and detrusor contraction when there is higher bladder volumes. What's wrong, baby? What are you looking at? Okay, let's go. Come on. Okay, let me go through your questions now because I wanted to get all of this out. Hang on, guys. I'm looking through these questions. Yes, some people can self-catheter. So people who have spinal cord injuries, if they have enough dexterity, if they have enough cognition, if they have enough visibility and vision to self-catheter, certainly They are encouraged and taught to self-catheter because these people have to engage in intermittent catheterization, because you can imagine they do have a neurogenic bladder, so they do have, they will experience They will experience post-void residual urine, so that's like leftover urine in the bladder. Who teaches them? I don't teach self-catheterization. There are nurse continence advisors, that's what they call themselves. They'll have different names, but there are nurses out there that specifically teach self-catheterization. Okay, let's see. Nurse continence advisors. Yes, so inserting catheterizations for some people is very painful. It can be very painful, especially if you have some kind of urethral obstruction issue, if there is weakness in the urethral walls, usually with atrophy, multiple systems atrophy, dementia, Alzheimer's, you'll find this. So actually people who do need a catheter because they have an issue with the external. So there are issues sometimes where you will have contraction of the detrusor, but then there won't be the relaxation of the sphincters. So that's where you have that detrusor sphincter dyssynergia, where they're not working together. You'll actually have contraction of the detrusor and also contraction of the urethra, of the sphincters. So that's a big problem, because the detrusor, the bladder, is doing what it needs to do. That's like overactive bladder. It's contracting. Okay, so this is exactly what happens in overactive bladder, guys. Frequency, urge. You have contraction, but you don't have necessarily relaxation of one or both of the sphincters. Okay, so some people need what's called a transcutaneous suprapubic permanent catheter. So yeah, it's exactly what it sounds like. They have a suprapubic, so above the pubic bone, transcutaneous through the skin. It's a hole that's punctured, surgically made through the skin, through the tissue layers, through the muscles that go into your bladder, into the bladder, to help get the urine out. It's a catheter that is suprapubic. It doesn't even go through the urethra because the urethra is collapsed. There's obstruction. Something's up with it. They couldn't get it in that way. And sometimes, you know what? It's way better, because that can be so painful, having something in there for such a long time. So people with spinal cord injuries, they don't necessarily feel it. Usually they don't, depending on where their injury is, unfortunately. They don't feel that. So they don't have to worry about what they feel every time they self-catheter. Noxious stimuli, so let's say they've inserted it incorrectly or something is, well, okay, this is going to go off topic, so I'm not even going to go there. Okay, where was I? I had soda pop now that I've been down here so long. Soda pop. Yep. Yeah, I should interview you, Elsie, about all of this. How you did such a great job speaking on this topic, and why people are opposed talking about it, or why people don't talk about it. So thinking about it has to do with the brain. You're sending a lot of information. All the neurons are firing in the brain, and usually it'll send information to that pons micturition center. So that's why it can feel like that. You'll get a message to the detrusor. It's like this constant negative feedback, like back and forth. So the more you think about it, it's like this back and forth between the system. So it gives you the sensation. You're more aware also of the sensation. But then you have that assessment of social appropriateness, right? So we can override that, just the thought of it, because you're like, oh, well, this is not socially acceptable. I'm sitting on the couch. I can't just pee myself, right? So that's where the the voluntarily controlled motor fibers kick in to the pelvic floor, the somatic fibers, and then they override that. The sphincters contract. Then you have the external sphincter contracting. So what does the internal one do? It follows. It'll follow. So hopefully that gives enough of, it's like this stuff is constantly going. You're like a computer, guys. So when I explain it, it's like I'm explaining it slowly, but this stuff happens like at the speed of light, right? And it's like a constant. So like when I speak about the parasympathetic and sympathetic nervous system, they're always on at the same time. It's just that one is overriding the other. One is either overriding the other. Come here, amorcito. Involuntarily is autonomic. Yes. I never knew so much information. Oh, yay. And you're a doctor. Why just thinking about it? Okay. Do you have a flashlight? No, I didn't have a flashlight. The clouds look cool. Okay, guys. Bye.